is almost hilarious. If I wasn't so tired, it would be hilarious. The keycard system isn't working anymore. I think it stopped working at midnight, which means that I basically can't access lots of places in the hospital, including the personnel on-call room, which is where I have all my stuff, and it is where I've been trying to sleep. Although, to be fair, I haven't really had a moment so far, so it's not that bad in terms of not having access. So I found a nurse who did have keycard access for some reason. It's making the job a little trickier than usual, but we're getting there. We're finding solutions. That's the most important thing. So as long as I can get from the on-call room to the patients, we'll be fine. This is why we like nights. A different set of challenges every time. Tonight has been pretty busy. I've been called for a bunch of sick patients, and then in between there's been a smattering of confirming a death and falls, lots of falls. But yeah, in between all that I haven't really been able to sleep at all, and I didn't manage to sleep during the day either, so I am lacking a lot of sleep. So I've just gone to the morning handover. So this is with the whole team, including the head of the department, and we just hand over anything that's happened overnight, and that way they can, if there's anything urgent to deal with, that's what they'll do straight away in the morning, and otherwise it's just good to know for continuity of care. Obviously I'll still write a note on the system in the patient's folder, but it's things like that can be missed, so that's why we do handovers. So I'm very happy about heading home, and I thought I'd talk a bit more about the cases that I saw and things to watch out for on nights, because you definitely learn a lot with experience. You can't just pick up a guideline for what to do with chest pain and assume that you'll be able to deal with every type of chest pain. There's things that you pick up along the way. So for example, I got a call about shoulder pain for an elderly patient from a nurse, and I just want to underline, because I don't want to make it seem like the nurse is giving false information or anything. She is relating what the patient has complained about, and with any handing over from a patient to a nurse to a doctor, all those steps of communication may inevitably lead to things that are missed in the process, things that are lost in translation. And so this nurse called me about some shoulder pain for a patient who had known shoulder pain. So you would argue that if it's known already, he's complaining about the same pain, then, you know, just give the usual analgesia. There's PRN, which is sort of reserve medication in case they need anything more, anything stronger, which is not given regularly every day. And the other thing to keep in mind is you can't go to see every single patient that you're called about. You know, you have to ask questions to the nurse. If you don't think it's anything that's necessarily concerning, you deal with a lot of stuff on the phone in front of your computer. You don't have the time to go see every patient in person. In the beginning, you will likely do that much more because you don't know what's worrying or not, or you're not sure and you need to reassure yourself. One could argue that I'm still overseeing patients, but I guess you never know if you're doing too much until you miss something. So I suppose I am very prudent. But anyways, this patient I went to see, and it was in fact not his typical shoulder pain that he was complaining about. It was right-sided chest pain, so a different localization to his shoulder pain. The shoulder, I can't recall, I think it was arthritic changes, and it was pain on mobilization of his elbow joint. Here we were talking about a new right-sided chest pain for a patient who had a known cardiac history, and so that's a whole different story. So for him, we ended up doing an ECG and sending off some drops because the ECG was normal, but he still had chest pain. So these are markers that give you an idea if there's any muscle damage in the heart. The first drops were not raised, and equally the second pair of drops, because you do both to look at an interval over time. It won't give you an accurate reading to just look at one. So the second one we did at the 3rd hour, and that was also not raised. So all that was reassuring, and his pain subsided anyways. But the point of these cases is just to underline how the story can differ and why it's really important to take a good history from your patient, but also when you're on call and you're trying to battle lots of phone calls and prioritize which ones are the most important. For something like chest pain, these symptoms and the history are really important, especially for elderly patients. It can easily be disguised by anxiety or shoulder pains or just not feeling generally well, and older people have a tendency not to complain as much. I think there's actually research that's been done on this about how elderly patients will underplay their injuries, whether that be pain or if they've had a fall, and they won't necessarily complain about anything significant, and you do a CT scan and you see multiple fractures. And there's a combination of reasons for that which we won't go into, but the point is, have a low threshold of suspicion, especially for something like chest pain. The other case that I wanted to talk about was epistaxis, so nosebleed. Now this is surprisingly common in ED. I was called on the ward for this, but in ED, the presentation of a nosebleed is very surprising. I think, I'm not going to make up a statistic, but I'll put it here somewhere. It's very helpful to know what to do with a nosebleed because it's very common. And even as a first aider, you know, if one of your family members or somebody you know just starts having a nosebleed, it's really helpful to know what things you can do in order to stop the nosebleed and stop the patient from having to go see an ENT doctor. And when I think about 80% of cases of nosebleeds could actually be managed in ED rather than referring to ENT. So there's definitely a good level of interventions that you can put in place as an on-call doctor by yourself. Like anything, you want to focus on your basics. So whenever you are faced with something that you don't necessarily know how to manage, go back to your basics. If the patient's airway is patent and they're hemodynamically stable and you're doing it your ATE and there's nothing necessarily worrying, then you've got some time. You've got time to figure out what to do, to look up the management of epistaxis, because yes, the truth is you will have to deal with things on your on-call that you either can't remember exactly how to deal with, or you may not know how to deal with. And depending on the level of gravity, you may want to discuss with a senior, or it may just be a question of refreshing your memory and looking up the correct medication or correct dose. But whether you're a doctor in training or you're just a curious onlooker trying to find out how much doctors actually know, it's not possible to know everything, and a lot of us suffer from major imposter syndrome, which I will make a video about. But the point is, it's normal not to know things, and it's normal to have to look things up. This is why on-calls are such a great learning experience, because you're left on your own, and so you're out of your comfort zone and you're pushed to those limits, the limits of your knowledge. So back to the nosebleed. You can have different types of nosebleeds, and so you want to think of the cause for this patient. Is it a traumatic nosebleed? Has there been a fall, a fracture, or is it a non-traumatic nosebleed? You know, has the patient been picking their nose, or is it a particularly cold season and they had an upper respiratory tract infection, which can increase the risk of nosebleeds? So find out the cause, get a history from a patient. I like to have a structure so that I don't sort of miss out important things while I'm dealing with a patient. And by structure, I mean just like you have your ATE, I just ask myself questions. So I do my ATE, I do a quick history and examination. And in terms of my management, because it's very easy to miss steps, especially on a night on call when you're tired, I'll just ask myself simple questions. So have I checked the resus status? Have I checked medication and allergies? So these are really simple things that you should do, but you can forget to do them. So for example, if a patient is on a blood thinner and they're bleeding heavily from their nose, you might want to stop that blood thinner. But if you don't think of checking medication, then that will easily be missed. And same thing for allergies. Before you administer whatever treatment, you know, always think, is there a contraindication for this? I think maybe even contraindication is a better question than allergies, because if you're, for example, prescribing analgesia, or you're prescribing a beta blocker, or whatever it is, always think, is there a contraindication? Whether that be an allergy, whether that be that they have really poor renal function. These are just little checks that I mentally go through to prevent problems can also increase the risk of nosebleeds. Now, obviously, the depth that you go into will depend on the severity of the nosebleeds. If it's a tiny little trickle, you may not want to spend, a good amount of time going through a deep and proper history if the patient just told you, oh, I was picking my nose and now there's a little dribble. And this is why you can't learn everything from the book. You'll pick up the context of the situation, the gravity of the situation, and you'll act accordingly. In terms of investigations, if a patient is hemodynamically stable and the bleeding is not significant, then you may not want to do anything at all. There are recommendations. It depends on your hospital and the guidelines that you're following, but there are recommendations of always doing a simple, putting in a simple cannula, at least a green one, and doing basic bloods, so full blood count, use knees, etc. But not necessarily coag studies, unless a patient has a known family history or relevance in their medication. So you've done your history, you're doing your examination. Oftentimes for a nosebleed, it's going to be, well, most of the time, I believe maybe 80 or 90% of the time, it's an anterior nosebleed. So in an area called Little's area in your nose, which is on the anterior side of the septum. So the septum is the middle bit, and on the side, that's the front. On the front side, that's usually where you'll get nosebleeds, because there's lots of anastomoses of little vessels, so lots of connections of little vessels together. And if there's trauma to that area or friction or whatever it is, then it will likely bleed. Posterior bleeds are more complicated, and that's often when you'll need more interventions and may even need to contact the ENT doctor or your senior. But the key is, if your patient has little bleeding and hemodynamically stable, you shouldn't be too worried. If your patient is bleeding profusely, you're watching out for whether they're hemodynamically stable, if their airway is patent. While you're initiating whatever management, which we'll talk about, just make sure that they're not completely isolated, because you may need to keep an eye on them. So in terms of first aid, things you can do in your kitchen with regards to nosebleeds is to tell the person to lean forward, put their head down, and squeeze on the soft part of the nose, so the tip of the nose, and just press down and hold it for a couple of minutes, if you can, for 10 minutes. You're leaning forward because you don't want the blood to drain back into the throat, because that's not pleasant, and also you're putting the airway at potential risk, whereas if you're leaning forward, it's all draining out anteriorly. The squeezing bit obviously is to put pressure and stop the bleeding. There are studies that show that you can suck on an ice cube as well, and that can help, but not doing anything like ice on your forehead or on your back. That doesn't do anything. And equally, you can put an ice pack on the nose, but the most important thing is to apply pressure and lean forward. So that's the first aid stuff that you can do, and a lot of the time it's enough to stop the bleeding. If it's continuing and you're in an ED setting, for example, or on the ward, when you're examining the nose, and if you see that it's an anterior bleed, it's not a lot of bleeding, you can cauterize. So essentially that's using silver nitrate. It usually comes in a pre-prepared pack, and you, almost like a pen, and you dab it on the area of the bleed. So if there's too much blood, you won't be able to do this. But if it's a small bleed and you can see the site of the bleed, you can cauterize. So essentially burn the vessel so it stops bleeding. You never want to do this on both sides of the septum, so in this nostril and that nostril, because you risk perforating the septum and other complications you don't want to have. But using an antiseptic nasal cream like Naseptin and cauterizing often does the trick. If that doesn't work, or if the patient is bleeding more profusely and you can't actually localize the site of the bleeding, then you may want to pack the nose, and that's essentially putting pressure. I don't know what material it's made of, but it looks a bit like a tampon, and you soak it in sodium chloride, and you put it in a nostril as vertical as you can, and then you inflate it, and that puts a good amount of pressure to stop the bleeding. And oftentimes that will be enough. If you're getting to the point where the packing, where cauterizing is not an option and packing is not working, it's not stopping the bleeding, or you can see that the patient's airway is starting to be put at risk, or if it's a posterior bleed, or if the patient is hemodynamically unstable, all those things you want to speak to a senior and possibly refer to ENT. In an emergency setting where you don't have an ENT person available, so ENT is ear, nose and throat, by the way, so they're the specialists that can deal with the rest of the situation if you can't handle the bleeding with these steps. But in an emergency, when you need to protect the airway, you can always insert a catheter. I've never done this, but in theory you can always insert a urinary catheter, like a 14 French catheter, into the nose, into the airway, so that you can see it in the pharynx, and then you inflate the balloon and you slowly tug up, and what that does is it blocks the passage of the blood going posteriorly and putting the airway at risk. So that's just sort of an emergency last resort that you can use, but it's not something you should have to use in your typical hospital, whether it be ED or the ward. Oh, I forgot to mention, you can always use suction as well. If there's a lot of bleeding, you may need to suction before you cauterize or before packing the nose. So that's another thing that's available to you. So that's pretty much how you manage nosebleeds, broadly speaking. I think it's a pretty handy one to know about, because it's not necessarily a complicated presentation, but you need to know what options you have available and what things you can use when. So when I was in ED and I dealt with this as well, I was shown to use Naseptin cream and cauterize, but apparently this was a study done in children. There's no significant difference between the use of antiseptic nasal cream and cauterization, which is interesting. And it also means that if you can avoid cauterizing, because it's slightly painful, and especially for a kid, you don't want to do that, antiseptic cream would be sufficient and equivalent. So that's an interesting one to keep in mind. Obviously, you always have your hospital guidelines and protocols, so do use this as a general guide, and this is mostly more to tell you about cases you may be called about, and how to initially manage them, things to keep in mind. So for the rest of the night, I was basically called for things like PRN meds, which are medications that you only give if a patient requires, whether that be antiemetics or painkillers, and it's good practice for your patients to, during the day, to put the necessary reserves, whether that be for insomnia or pain or nausea, the common things that patients may complain about, and that way the nurses have the option to give a medication to a patient without necessarily having to call the on-call doctor, because if it's a busy night and you get lots of calls about PRN meds, it's not ideal. So yeah, that was my night. I'm driving back home. I will probably not sleep straight away because I suffer from adrenaline rushes after nights, and I just can't get to sleep. So especially since I slept a couple of hours last night as well. So I'm probably gonna just go about my typical day and sleep a couple of hours in the afternoon before going back to my night shift. I know I definitely don't sleep enough during my week of nights, because by last night I'm just exhausted, and although I know I need to sleep, I just find it tricky to sleep multiple hours during the day. It just feels unnatural. I mean, it is unnatural, and I don't think the nights are long enough for you to get used to this routine before going back to your day shifts. So yeah, it's always a bit of a roller coaster. Nights are very formative. You learn a lot, but it's also not the best for life as a human being with regards to your social life or your sleeping patterns. But there we have it. It's an intrinsic part of being a doctor. I don't know anyone who's been able to avoid having night shifts, except I suppose if you have kids or if you're pregnant. Depending on the guidelines and your hospital contract, then you can have exceptions to the rule, but otherwise you're stuck with nights. I hope you found these cases useful, and if you'd like to know more about the things that I see during my night shifts, if you have particular questions about on-calls and how to deal with them, how to prepare for them, then don't hesitate to leave a comment down below. And if it's something that's useful, I will definitely make more, because I enjoy making them, and I definitely enjoyed watching them when I was in medical school. I still watch them. It's interesting to see how different doctors deal with different things, and it's always revision. When you tell somebody about a case you've seen, you're essentially reviewing a certain management, and it's always a good thing to do. Should probably have been at the beginning of the video, but disclaimer, this is just the way that I have learned things based on the protocols that I follow. They're not the absolute golden rules or guidelines. They're just things to keep in mind to help you on your shifts, but always link back to the official guidelines, whether that be national or your trust guidelines, and don't